Hello, it's Dr. Garrett Pohlman, host of the Prostate Health Podcast. Today we'll be talking about radiation therapy for prostate cancer and have radiation oncologist Dr. James Yu joining us. We'll focus not only on some of the basics of radiation therapy for prostate cancer, but also some emerging advances in this area. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. The Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. Joining us today on the Prostate Health Podcast is radiation oncologist Dr. James Yu. Dr. Yu is the director of Yale Medicine's Prostate and Genitourinary Cancer Radiotherapy program. His clinical aim includes treating his patients with state-of-the-art, evidence-based care that takes into account not just their medical condition, but their values and goals. He also conducts research on ways to use radiotherapy treatments to improve outcomes for cancer patients, including comparing effectiveness of new radiation technologies and how these new technologies are adopted nationally. Dr. Yu, welcome to the Prostate Health Podcast.
Hey, thanks for having me, Garrett. It's a pleasure to be on.
I'm really excited to get into some of the new advances currently in radiation therapy, but before we get there, I think it would be good to cover a few basics first. A lot of patients are curious, how does radiation therapy work in treating the prostate cancer?
So radiation is very, very mysterious, right? I mean, it essentially is all around us, right? And the electromagnetic spectrum starts from it starts way down there, but it includes radio waves to visible light, all the way up to therapeutic photons or X-rays, or if the photons start out from a nuclear decay, it's called a gamma ray. But it's the main kind of way we treat prostate cancer is through X-rays. Now, X-rays kill cancer by breaking the DNA of the cancer cell so it can't divide. X-rays also cause damage to normal tissue through that same DNA damage. The difference between a cancer cell and a normal cell is that the cancer cell isn't able to repair itself as well as a normal cell. And so that's where the therapeutic index of more damage to the cancer comes from. So short answer, radiation damages the cancer cell, the DNA, it can't repair. And cells that don't have good DNA don't keep replicating, they don't keep growing. And that's how we stop cancer with radiation.
Dr. Yu, we've already touched a little bit on surgery as an option for an individual with newly diagnosed prostate cancer. Can you just briefly review with our listeners some of the various options currently for treating their prostate cancer with radiation, as far as just some of the basic options?
Sure. So there's two families to think about when you think about radiation for prostate cancer: inside-out radiation and beamed-in radiation. The inside-out is a technique called brachytherapy. And the beamed-in radiation is a technique called teletherapy. Now, in the brachytherapy family, you have what's called low-dose rate permanent seed implant brachytherapy, where radioactive seeds are permanently put into the prostate. They're like the size of a grain of rice, and they're put in through a long needle into the prostate. High-dose rate brachytherapy is a kind of inside-out radiation, but instead of permanent seeds, they put catheters in to the prostate and temporarily place a very radioactive seed in the prostate in different positions in the prostate and eventually give enough radiation to kill the cancer. Now, beamed-in radiation, teletherapy, is a whole nother ball of wax. It uses big machines the size of a linear accelerator, which is, a small car, all the way up to the big behemoth city block machines that you see like in Philadelphia or Houston, for example.
So can you walk us through the process starting with external beam radiation therapy that you talked about in terms of, what can someone expect in terms of, pre-radiation planning, how many treatments are involved and, some of the various approaches to the beamed in radiation?
Sure. So the predominant form of beamed in radiation is photon-based. And we can go over protons down the line, but for now I'm going to focus on photon-based radiation. And the main form of modern radiation is something called intensity modulated radiation therapy, or IMRT. How do you get to an IMRT treatment? Well, first you meet with a radiation oncologist and you have what's called a consultation. You sit down, you talk about the risks and the benefits and how long the treatment's going to take, yada, 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 and if you're a good candidate for radiation. Once you're decided to go down the radiation path, sometimes that involves hormone therapy in combination with radiation. It's a whole nother ball of wax we can get to in a different question. But the steps to get to radiation, the first thing you need to get mapped. In other words, we need to make a 3D physical map of your body, and we use a CT scanner. Almost all the time, it's what's called a non-contrast CT scan because we don't need to give iodinated contrast for mapping out, where your prostate is in your body. So we do a CT scan. Typically, that also involves making a mold of your body. It starts out like a bean bag and they suck the air out and it kind of turns into like the bottom half of the Han Solo carbonite, except it's more like styrofoam. We do a CAT scan, mark your body, and then we go do our homework and you go home and you wait. How long that homework takes, typically on the order of about 8 to 10 business days. That homework, we can go through those steps as well, but it involves a specialized computer person called a dosimetrist planning your treatment based on what I or my resident together with me have contoured, i.e. kind of painted out, treat this, avoid that, that sort of thing. The dosimetrist shows us a plan. If we like it, then it goes to a physicist. The physicist delivers that radiation plan to a water phantom. Now, that phantom is typically like a water box, and it makes sure that the radiation that's calculated to be delivered is within a couple % of the radiation that is actually delivered. Once that physics check gets passed at Yale, a second physicist checks it, then a second dosimetrist checks it, then the therapist checks all of the boxes, and then you're good to go for a treatment. Then some institutions, including Yale, we do something called a VSIM or a virtual simulation where we do a dry run. And that way we test, okay, is the machine going to, hit the table in this part of the plan? Are you positioned correctly? What other things do we not think about during the treatment planning process? Once that virtual simulation, everything passes, this airplane is ready to take off and we'll deliver your first radiation treatment. So it's a long and involved process. It really shouldn't be rushed if you can help it. And it's a very teamwork intensive treatment.
And so you talked a little bit about how many, calculating the dosage and so forth. And so can you talk a little bit about, the different types of approaches, how long or how many weeks does that entail for the patient? And when they're actually there for the treatment, how long are they spending getting this treatment while they're at the facility? Right.
So once treatment starts, so we can deliver the radiation treatment as short as, some centers around the country are doing we're testing like in a phase 1 study, a phase 1 meaning a safety study or phase 1/2 safety efficacy study. Folks have looked into one treatment, which I think is quite extreme. Nobody's really doing one treatment. The shortest that we see around the country is around 5 treatments, up to what's called moderate hypofractionation, which is speeding it up a little faster than we used to do, and that's on the order of 20 to 28 treatments, up to what's called conventional fractionation, which is what most people are still doing in the U.S., is my guess. And that's on the order of 38 to 45 treatments. Now, these are daily treatments Monday through Friday. So if you're getting 45 radiation treatments, that's 9 weeks of daily coming into the radiation oncologist center and getting treatment. That can be a long course of radiation.
And so they're coming in for these daily treatments, but they're not there for a too terribly long time, correct?
Correct. Yeah. So typically an IMRT treatment is for prostate is thought to be what's called a simple IMRT treatment. If it doesn't involve radiating the pelvic lymph nodes or other areas, you're typically put into a 15-minute time slot. And even if you're treating pelvic lymph nodes, at least at our institution, we still put you in a 15-minute time slot. You should be in and out in a very kind of regimented and predictable way.
So you had discussed, some of that pre-radiation counseling in terms of the risks and benefits. For our listeners, can you just outline just some of the potential side effects of you counsel patients on in terms of for external beam radiation therapy?
Sure. So all the side effects that occur with radiation are all right by the prostate. And what's by the prostate? The rectum runs immediately behind the prostate. That's why when you come to get a prostate exam, you can feel it through the rectum. Urethra runs right through it, and then the bladder and bladder neck are right above it. And also those neurovascular bundles come right around it. So those three things, rectum, bladder, urethra, and neurovascular bundles, those are where the side effects come from. So bowel irritation, up to as bad as, very, very rarely, severe rectal bleeding, a hole in the rectum. If you are for some reason very, very sensitive to the radiation or something goes wrong and you get a ton of radiation to the anterior rectal wall, you can get a perforation or a fistula. The urethra that runs through it, most of the time it's irritation, more frequent urination, more obstructive symptoms, more hesitancy, getting up to the bathroom more often at night. And that typically goes away after a couple of months. Every now and then, very rarely, you can get a stricture or, scar formation or block off the urethra and be unable to urinate. Those neurovascular bundles, typically you get a little hit to your erectile function, but it gets pretty close to baseline. And I can say that based on that UK Protect study that was in the New England Journal a couple of years, actually is almost a couple of years, it's like a year and a half ago, right? Showing that actually sexual function's pretty good after radiation. It's not like you didn't have radiation, but you should have decent return of your sexual function after radiation. That's the big three. Now, the fourth one that we didn't talk about is the second malignancy, right? A cancer caused by radiation. We know radiation damage to the DNA of normal tissue could potentially cause a cancer. What that absolute risk is very, very difficult to calculate. It's more than zero. I think it's less than 1% or even 0.5%. But that's a very, very difficult study to do because you have to follow patients over years. The incidence is so low, it's hard to take from a randomized cohort. So you have to do an epidemiologic study using population data. And then that gets into the whole, are the folks who get surgery less likely to have a second malignancy because they're healthier? It's a very, very difficult study to do. And so a lot of the second malignancy data, though, is from like Hiroshima and things like that. And that's whole body dose. It's very difficult to translate that to like a rectal or bladder cancer risk from radiation. But I do counsel patients that radiation can cause a cancer. The risk is probably low. We'll need to surveil you. And if you have, chronic bleeding from your bladder, we should probably look up there with a scope at some point. If you have chronic bleeding from your rectum and you haven't had a colonoscopy recently, we should probably, look up in there. We used to tell, and I was taught that it takes 10 to 15 years to develop a second malignancy. It's probably shorter than that in some cases. So again, it's a very difficult academic question.
And that's what makes it more difficult when counseling patients regarding prostate cancer, whether it's radiation or surgery, there are potential consequences, which, makes that decision a little bit harder. It's not like you're removing a kidney, you've got another one, you're not affecting, sexual function potentially or urinary control. And so it definitely is a decision that needs to be made with, a lot of information and carefully, discussing these options with their providers. So.
Yeah. And I'm glad you had on your prior podcast, if the listeners haven't heard it, the one from Judd Moole from Duke, he and I and a guy named Dan Hamstra wrote a nice point-counterpoint that was published in Oncology, I think in 2017, about which is the better treatment for quality of life purposes, surgery or radiation. And if listeners want to go to that, it's a nice perspective from both the surgery and radiation sides. So it's, again, they're so different, surgery and radiation. It's so difficult to try and compare which one to go for. It's almost like a philosophical decision than anything else.
Yeah. Now, you had mentioned earlier the option of the brachytherapy or the radioactive seeds. Now, when counseling your patients regarding options, there are certain scenarios where you may lead toward one or the other when looking at brachytherapy or external beam radiation therapy as options.
Yeah, so brachytherapy is, I think, a very convenient way of being treated. It's very cost effective from a health system standpoint, except use of brachytherapy in the United States is going down significantly. Part of the reason for that is IMRT delivery and treatment, I think, is actually easier for the provider compared to brachytherapy. Brachytherapy is very user dependent, meaning you have to do a lot of these to get good at them. And the third thing is Da Vinci robot was invented around the time brachytherapy was going down. And I think those kind of favorable or low intermediate risk patients, the urologists were a lot more interested in doing surgery than brachytherapy, which is kind of a partnership with radiation oncology. So nationally, those numbers are going down. Could they be kind of coming back up because of a recent study out of Canada showing that brachytherapy boost may be better in terms of cancer control compared to standard fractionation radiation treatment? I'm not sure, but it's an interesting time. I think we should keep watching brachytherapy, but generally brachytherapy, what's called monotherapy or treatment where only brachytherapy is given for prostate cancer, I think national trends are on the down slope. I don't know how they are at Colorado, but out west, kind of where there's more room, more people have to drive further, brachytherapy may still be in more frequent usage, but again, nationally, those numbers are going down.
Now, with some patients still undergoing the brachytherapy, for our listeners, can you maybe describe in terms of, how are these seeds implanted and, kind of what sort of a process is that?
Yeah. And so we're talking about low dose rate brachytherapy, of course, but the first thing that happens again is a consultation with your physician, and hopefully you've had some sort of imaging of your prostate already and that you can have a general sense of whether you have an enormous prostate or just a regular prostate cancer sized prostate. But if it's enormous, you may not be a good candidate for brachytherapy because, the bigger the prostate, the more seeds you got to put in there. Once you're deemed a potentially reasonable candidate for brachytherapy, you come into the radiation oncologist or urologist office and you have something called a volume study. This is an ultrasound study of your prostate where a rectal probe, an ultrasound probe is inserted and your prostate is mapped. So if you recall, when we talked about photon radiation, we mapped your body with a CT scan. This is a very specific mapping of your prostate with an ultrasound. Then the radiation oncologist goes and does their homework while you wait. Typically, then you get your procedure scheduled. The radiation oncologist on their treatment planning software decides where the seeds are going to go. And then you come in for your procedure. If it's the radiation oncologist that you have decided to go with uses what's called stranded seeds or linked seeds, they'll have to order them ahead of time. Sometimes those seeds are connected. And so instead of putting in individual seeds, you put in these strands of seeds, and they can actually make a very beautiful implant. Some people, though, still use the free seeds because there's a little more flexibility with that. You come in for the procedure, you're all prepped. It's in the operating room. They numb you up and, use some sort of whatever anesthesia that the urologist and radiation oncologist feel like is the right one. And those seeds are inserted through what's called your perineum, which is the space between your testicles and your anus, using long needles. And hopefully, the team that you've chosen has done a lot of these or do a lot of these. You want to go to a high volume center. Full disclosure, you don't want to come to New Haven to get this done because we don't do a lot of brachytherapy. So folks come to me, I say, go down to New York or Boston. If you're in the Seattle area, the folks in Seattle do like tons of these and they're absolutely beautiful implants.
Now, we kind of talked a little bit about, you alluded to the androgen deprivation therapy, hormonal or ADT, which is often given in conjunction with external beam radiation therapy. Now, for our listeners, what that means is using medication or surgery in some special cases to bring a man's testosterone level down to very low, what we call castrate levels. Can you talk a little bit about the rationale behind why this is given in conjunction with radiation treatments, and maybe how long does somebody need to be on that treatment?
Yeah. So, that surgery you talk about it's called castrate. So, it's a tough one. So hormone therapy has been shown to be beneficial in terms of cancer control in combination with radiation in multiple randomized studies. So typically for the highest risk or higher risk patients, we really push testosterone withdrawal, because if you have a high-risk prostate cancer, long-term hormonal therapy has shown to have what's called a survival benefit. And for the listener at home, this means that, the group of men they flipped a coin and gave the testosterone withdrawal therapy, that group lived longer than the group that didn't get the testosterone withdrawal. So that's, as you know, that's the gold standard for a treatment that is effective. If there's a survival benefit, there's an overall survival benefit. So in the modern era, when we give external beam radiation for high-risk prostate cancer, we always give long-term hormone therapy. In the United States, it's anywhere from 18 months to 36 months, and it depends on your practitioner. It also depends on how aggressive your disease is. Now, in the intermediate risk folks, those are your Gleason 7s, Gleason 4+3s, so your unfavorable intermediate risk patients. Those are the folks that are getting 6 months of testosterone withdrawal. And that's a little bit based on extrapolation from older studies showing, one study showing a little bit of a survival benefit, the rest of the study showing, prostate cancer control benefit. We think that those unfavorable intermediate risk prostate cancers act more like the high riskers. And so we're a lot more aggressive in those patients. Now, the Gleason 3+4s, right? The primary score of 3, secondary score of 4, those favorable intermediate risk prostate cancer in the US and I think around the country, around the world, we are a lot more often not giving hormonal therapy based on a couple studies that have shown that those guys may not need that aggressive therapy. And if there's one thing about men, they hate getting their testosterone taken away from them. That is like the biggest. They can have all sorts of problems with urination, bowel movements, whatever. They're just like, Doc, I feel terrible. And so, yes, there's some guys who feel okay on the ADT withdrawal, but that's a tough treatment. And believe me, as a research group, all around the country, people are looking at ways to avoid ADT. And if your doctor recommends it, you probably need it.
Exactly. Now, following radiation therapy, what do you counsel patients in terms of monitoring their PSA following therapy and what they may expect in watching their PSA?
Yeah, that's a great question. So, actually on an email thread a while back, and it's all these I felt very privileged to be on this email thread. It was all these big names in radiation oncology. And somebody emailed out, was like, hey, what do you guys do for your follow-up? And I swear, all of these huge names in radiation were we follow our patients every week for the rest of their life, essentially. Or not. But it was I was really surprised by that. So I think this is what I do. Take it with a grain of salt and know that maybe my follow-up regimen isn't as intense as these giants in radiation. But I see a patient 1 month after their radiation and we just sit down and have a conversation. I don't even check their PSA then, because radiation treatment response is a long, slow decline. I don't want them to freak out if their PSA is relatively unchanged. I see them at 4 months after. That's when I check their PSA for the first time and I look for a trend. Then I check 6 months after that. So at the 10-month mark, I check, and we should see a continued decline. Then I check yearly thereafter. PSA nadir after external beam radiation takes anywhere from 1 to 2 years. So this is a long, slow decline. If they're extra anxious, maybe I'll get another PSA between the first and second year. But other than that, I don't follow them overly intensely.
Certainly.
And then I do that forever, essentially. I had one guy I treated at the beginning of my career. So I've been in a radiation, I've been attending, this is my 11th year now, something like that. So a guy I treated 11 years ago, and his PSA is rock bottom. It's 0.1 or 0.2, something like that. I finally was like, listen, man, I don't think I have to see you anymore. And he was like, yeah, I've been waiting for you to say that. So, and primary care doctors are, they're all over the map, right? We're keeping it real on your podcast. So primary care providers all over the map. Some of them are very good at PSAs. Some of them freak out if it's detectable. So, I think as long as there's open communication between the primary care provider, radiation oncologist, or urologist, they can follow maybe after 5 years or something.
So you mentioned the term nadir, and so for our listeners, maybe kind of go into a little bit more about, kind of what that means in terms of the PSA, and how would you define a cancer recurrence after external radiation therapy?
So that is a very interesting question, right? So PSA nadir is exactly what it sounds like. It's the bottom point. It's like, how low can your PSA get? And we think that kind of decline in PSA, again, happens 1 to 2 years after radiotherapy. How low should it go? As low as possible. There's been, as you know, in prostate cancer, there's 1,000 new papers out every week because we have hungry residents, hungry medical students, prostate cancer, high volume. So there's been multiple papers showing that the lower your PSA nadir, the better. Under 0.5, I think, of course, is better than under 1.5. There's been some evidence that brachy and SBRT, which we'll talk about, I assume this, 5 treatment radiation have lower nadirs than, standard fractionation. Basically, the lower you can get it, the better. What do we define as a recurrence? Well, before 10 years ago, we used to define recurrence after radiation as 3 successive rises, and then you would backdate to the nadir. And then very smart people came together and said, that's ridiculous. We should come up with a better definition. And now the definition, which came out of Phoenix, so it's called the AstroPhoenix definition, is nadir plus 2. So if you go down, your PSA is 0.3, and that's the lowest it ever got, you're not in biochemical failure until it reaches 2.3.
That's a very good explanation. Thank you. So now for patients that have looking at PSA recurrence after surgery, that would be anything, 0.2
right.
or higher.
It depends, right?
Yeah.
I think, wasn't it, now we're talking off the cuff, but I feel like the AUA definition for a while was 0.2 or 0.1. And if there was an editorial from a very prominent urologist that was like, that's the only reason it was like that was because that's just historical. That's as low as we could detect before. So undetectable obviously is undetectable.
Yep.
But then what trigger do you have after surgery to start something? And that is an active area of furious debate, I think, probably in Colorado, in New Haven, where I advocate for 2 successive detectable PSAs, no matter how low they are, at least start the conversation about salvage. I've started radiation as low as 0.01, 0.02, with the idea that the lower it is, the more likely you are to get a cure from radiation. Now, the converse of that, I recognize, is also true. The lower it is, and if it just goes from 0.01 and a year later it's 0.015, do you really need to do anything for that? I don't know. I think it depends on the patient's and the physician's philosophy as to, number one, do you want to err on the side of curing, or do you want to err on the side of preserving quality of life? And patients are all over the map on that. So everything in prostate cancer is a conversation with a patient.
Dr. Yu, very valuable information so far. We're going to take a quick break here, and then we'll be right back. Thanks again for joining us today on the Prostate Health Podcast. If you're enjoying the show today, make sure you visit my podcast website at www.prostatehealthpodcast.com. There you can find show notes to all our episodes. You can also click on our resources tab, where you can find links to our trusted partners of the podcast, as well as links to books, resources, and products, all of which can help in your journey with either an enlarged prostate or prostate cancer. You can also sign up to receive my free What to Expect guide, which includes checklists of what you need to bring and how to prepare, including what to expect with 3 different scenarios, including your initial urology clinic appointment, a prostate biopsy, or prostate cancer consultation. Sign up for the free guide on the homepage of www.prostatehealthpodcast.com or access this guide directly at www.prostatehealthpodcast.com/clinic. So in terms of getting radiation therapy after a surgery, you kind of walk through that process. How does that differ in terms of duration or type of treatment, or would you tell listeners it's pretty similar to, obviously there's no prostate there to target, but maybe just kind of go into a little detail about what we call salvage radiation therapy after surgery?
Yeah. Honestly, I think salvage radiation nowadays with modern technique is a little bit harder than intact prostate radiation. We have an annual meeting coming up later this year, so I'm going to say just vaguely, it may be that radiation dose to the rectum may be higher in the salvage setting, believe it or not, than in the intact prostate setting because of modern techniques and because of full disclosure, I get money from Boston Scientific to consult for them, but they do make a product called Space OAR, which is a hydrogel that's injected between the prostate and the rectum. You have to have the prostate there, and that actually reduces rectal dose. Again, full disclosure, financial conflict of interest here. They don't pay me per injection, but I just consult for them. And so with modern techniques, with that gel, we can get rectal dose actually quite low. If you don't have the prostate there, you typically can't put that gel in. And so even though you're using lower doses for salvage radiation, the rectal dose cumulatively actually may be higher in salvage radiation. So I also think that we radiate more bladder, which we do in salvage radiation, because you're no longer treating the prostate, you're actually treating an area of potentially left behind microscopic disease. And that actually standardly includes the bladder neck. So you're intentionally radiating the bladder there. So in my experience, salvage radiation is a little tougher than intact prostate radiation, believe it or not. It's a little bit shorter. So a standard treatment for salvage radiation, i.e. no prostate there, you're radiating to salvage, cancer, right? So salvage radiation is on the order of like 35 to 39 treatments standardly, whereas for intact prostate, it's like 38 to 45. So it's like a couple weeks shorter. There's no SBRT for salvage. So you can't give just 5 treatments. People are testing it, but it's not standard of care yet. There was a recently closed clinical trial called the NRG-GU003 study. I know that's a really sexy name, NRG-GU003 study, that tested 5 weeks of radiation versus like 7.5 for salvage treatment. So we may be able to shorten it by a couple of weeks if that study reads out as positive and, no additional toxicity. I think it's probably going to be, because in the patients that we randomized, the folks who got 5 weeks of radiation did great. So, for those of you out there who are keeping their ear to the ground for prostate cancer clinical trials, to me, that's exciting. I'm like looking forward to that in a couple of years. It's like the last Star Wars. I'm like looking forward to that one. Actually, last Star Wars came out, so I don't know. The next, Picard 2. Picard 2 in the nursing home.
So thank you for that. You've really given a great overview of just, radiation treatment for prostate cancer. I think we can, touch a bit on more in terms of some of the advances that you're seeing in radiation therapy for prostate cancer. And I know we've kind of hit on this a little bit already just in talking about some of the basics, but I know you've done a lot in terms of looking at moderate hypofractionization. Now, for the general public, again, what does that mean, compared to the conventional treatment again?
Yeah, so let's break apart those words. Moderate hypofractionation. So fractionation is how you break the treatment up. So hypo, meaning less, fewer fractions. Moderate hypofractionation is like not 9 weeks of radiation, it's like 6. Or, it's not 8.5, it's like 5.5, or maybe 4. So it just tries to be a little more, I guess, patient-friendly in that it doesn't make you come in every day, but it's not so extreme as gives all the radiation in a week and a half. So the folks who invented moderate hypofraction, well, I'm not sure they invented it, but the ones who, in my mind, popularized it are the Canadians and, folks in Europe. It's first started for breast cancer. Moderate hypofractionation, speeding up breast cancer treatments. And then prostate cancer world said, maybe we can do that also for these extremely long prostate cancer treatments. Multiple huge randomized trials. The one in the US led by Robert Lee showed that moderate hypofractionation was equivalent to standard fractionation in almost all ways. It was like a little bit more like what's called acute toxicity, meaning right away toxicity, but it really was, I think most of us would say, for the standard patient with intermediate risk disease or, those are all very good potential patients for moderate hypofractionation.
So we talked a little bit about the moderate. What about extreme, in terms of, and I think you had kind of alluded to this earlier in terms of the duration and kind of what they're looking at in some of the studies so far and comparing this to some of the other treatments.
Right. So extreme. So I think the people who popularized SBRT hate it when we say extreme hypofractionation or aggressive hypofractionation. But essentially, it's also known as SBRT, stereotactic body radiotherapy. Some people call it SABR, stereotactic ablative body radiotherapy. extreme or accelerated hyperfractionation. Basically, it means giving all your radiation in roughly, 2 to 6 or 7 treatments. In the United States, most places give it in 5 treatments. Why do we give it in 5 treatments? Because that's what Medicare says is SBRT. Well, also because those are the fractionation schema that were most studied, by folks at Stanford. Chris King did a lot of these great studies looking at SBRT for prostate cancer. So 5 treatments, typically every other day. I think people used to do every day, but found it was slightly more toxic. So every other day treatments, and then you're all done. If you get SBRT, it's slightly more intense in terms of tracking your prostate, right? Because instead of getting 20 to 45 shots and you miss one or you're a little off on one, it's not the end of the world. With 5 treatments, you want to make sure you're on. So it involves that first word, stereotactic, right? Stereotaxis, localizing the prostate in 3D space somehow, either with gold, or not gold. Well, could be gold. We use gold sometimes, but some sort of visible markers in the prostate that you can track. You can also use radiofrequency beacons to track the prostate. So stereotaxis, and then a little bit more kind of care in terms of designing the radiation treatment with very tight margins. And you give more radiation each time too, so that the entire course is completed quickly.
Now, I get a lot of questions from patients about proton therapy for prostate cancer. Indeed, I believe this is a more expensive than conventional radiation treatments. From your opinion, where are we kind of at now in terms of data and outcomes and comparing proton therapy compared to the conventional radiation treatments?
Yeah, so I think the key claim for proton beam was less toxicity. And there's some in the proton world who are kind of shifting to maybe more efficacy-based arguments. But let's address toxicity first. The idea is that a proton beam has a physical property called a Bragg peak. So any charged particle with mass has a physical property called a Bragg peak, where as it interacts with matter, once it loses all of its energy, it gives off its radiation dose at a depth in matter that is predefined by the energy. So if you can, basically shade different energies together in a beam, different particles of energy within a beam, you can kind of treat a volume in 3D space using just kind of either opposed lateral beams or maybe even a single or combination of those beams. And there's no exit dose. So photons have entry and exit dose. It kind of just smears through the body. And so the physical property of protons was thought to be good for treating things deep inside the body, like the prostate. And actually, the first hypothesis of this is not a new idea. This was actually like in the 60s and 70s. People were like, hey, let's treat prostate with proton beam. And protons have actually been around for a really long time. Mass General, the cyclotron to treat patients has been in use for decades. And down at Loma Linda, it used to be Mass General Loma Linda for a really long time, where the two centers doing this. And then somehow just kind of the medical train got moving and multiple places started treating with proton beam, probably because the technology got a little bit better. Now people can do what's called intentionally modulated proton therapy. So believe it or not, newer proton centers are looking at the older ones and saying, your technology is not as good as ours. So there's now even tiers in proton centers, for what it's worth. But that's the idea, is that proton beam will have less toxicity because of this lack of exit dose and much less entry dose. The problem is they haven't proven that. And there are still some uncertainties in the proton beam, what's called range uncertainty. And so you still have to put a little bit of a margin around the prostate. Anytime you put a margin around the prostate, now you're right into the stuff like at the beginning of the podcast we talk about. Everything's right around the prostate. And so you still get toxicity from proton beam. We did a study looking at Medicare claims. We did not detect a big benefit to protons. We found a little bit of a benefit to protons that was temporary and then went away after a year. Other folks looked at Medicare claims and found essentially the same thing, maybe a little bit more toxicity actually for the protons, depending on which kind of set of Medicare claims you looked at. We looked at whole country, what's called the chronic condition warehouse. There have been quality of life studies. A great one by Neha Vepiwala at Penn looked at their photon and proton cohorts and found no difference in patient-reported outcomes. The Florida folks have found a slight benefit to protons maybe. So again, all over the map, there's an ongoing clinical trial called the Particle, Partiqol, quality of life study that's being led by Jason Estathio and Justin Beckelman's phenomenal study. It's accruing over years, but hopefully they'll get enough patients on it. That will be, I think, the definitive answer as to whether protons are better than photons for quality of life. And I hope they're successful in that study. There's a new registry study that's ongoing. There's all sorts of study trying to figure this thing out from a quality of life standpoint. So efficacy standpoint, there's even less to stand on. I think some proton folks think, well, our beams we can cover more prostate. We don't have to lower the dose right at the rectum. And so maybe there's a little bit better control with the protons, but I am not convinced by that at all. And then we can talk about carbon ions too, but that's even further afield.
Well, I think that's certainly all been very helpful. And so, certainly maybe the jury's still out and, more evidence to accrue moving forward than sounds like.
Yeah, I mean, protons are an exciting technology. And, we're trying to get one in Connecticut, right? I mean, the Yale New Haven Health System and the Hartford Health System are partnering together, trying to get one in Connecticut. So, it's not like we're anti-proton. It's just that, is it the right technology for prostate cancer? Yeah, I'm not so sure about that. Would it be a better technology for, head and neck cancer, definitely pediatric cancers, reirradiation, definitely yes, skull-based tumors. There are other things that proton therapy would probably be more useful for. And protons for prostate is, because it's been relatively scrutinized, I'm still not convinced. I could be wrong. I've been wrong before, but I think I will certainly be waiting for that clinical trial to fully accrue. That's the other one. That's going to be like Guardians of the Galaxy 4 or whatever. I don't watch movies anymore. I've got kids. we don't have time.
I hear you. Oh. So as physicians, again, we're all about minimizing toxicity, if possible, and in terms of treating prostate cancer. Now, I know, again, you have quite a bit of experience with this new technology to help minimize some of the rectal toxicity with radiation therapy. And we talked a little bit about this earlier. And, tell our listeners just a little bit more about the space or hydrogel, and how's it administered? How does it work in terms of minimizing that toxicity and so forth? So,
yeah. So again, full disclosure here, I have a conflict of interest with the company Boston Scientific, which bought the original company, which was Augmenix. But the way this works is it's very simple, right? The rectum is normally right up against the prostate. It's a thin-walled tube right up against the prostate, right? So what's the best way to not damage the rectum? If you can push it back. How do you push it back? Well, you numb up the perineum. Everything's through the perineum these days. Numb up the perineum. You stick in a long needle and make sure you're in the space between the prostate and rectum. And you inject under ultrasound guidance, basically a gel. It starts out in 2 tubes. It's like epoxy. And as they come together, it mixes and it forms this gel. And it looks like, it's just a clear gel. It lasts for 12 weeks and then turns back into liquid and is absorbed by the body. That gel pocket will push the prostate away from the rectum. Typically is around a centimeter and a half. And that's all we need from a radiation standpoint to much more spare the rectum. The product is called Space OAR, and it's generally approved by most insurance companies and most Medicare NGS. I think all Medicare NGSs for preserving rectal quality of life during standard radiation and also during brachytherapy. You can give it right after brachytherapy to spare the rectum as well.
Well, great. Well, thanks for sharing that. And lastly, now traditionally those who are found at the time of diagnosis to have, unfortunately, spread of prostate cancer throughout their body, or what we call metastasis to various areas, traditionally those patients were not candidates to have their prostate treated with either prostate removal or radiation to the prostate. Now, I believe, with some of the new data suggesting that some of those individuals in select cases could potentially benefit from treatment of the prostate in addition to, hormonal therapy as well. Is this something that your center is starting to look at in terms of treating, these patients, but also maybe even treating some of the sites outside of the prostate?
Yeah, and this is a rapidly evolving area. The idea is that there is this intermediate clinical, let's talk about two basic themes here. So I think you talked about two basic themes,
Yep.
The oligometastatic disease, and then also the benefit of treating the primary tumor in metastatic disease.
Yep.
So for the first one, oligometastatic, let's break that word apart. Oligo meaning few, like oligarch, right?
Yep.
Few, metastatic, few metastases. In, I think, 1997 or something like that, Sam Hellman and Ralph Wexelbaum, two giants of radiation oncology, wrote an editorial in the Journal of Clinical Oncology hypothesizing that there is this intermediate clinical state between localized disease and disseminated metastatic disease, this intermediate state called oligometastatic that you could intervene with locally and stop the metastatic disease, or at least affect the clinical course. This is a radical idea at the time. In some cancers, like colorectal cancers, it's basically thought to be very true, right? If you have a single liver metastasis and, your colon cancer is basically taken care of, if you go after that liver metastasis, you can affect the disease course. You can, potentially cure a patient. In prostate cancer, that hasn't necessarily been proven, but a lot of us are really excited about it. And if you have just a few metastases, because radiation technology has gotten better, our ability to deliver an ablative dose of radiation with very few side effects has gotten better. We are getting much, much more aggressive as try and play whack-a-mole, zap those tumors as they arise. If there are few enough of them that you can do them safely, we are getting more aggressive. And we recent consensus statement from the American Society for Radiation Oncology and the European Society for Therapeutic Radiation Oncology coming together and saying, yes, if it's safe, if you have few of them, it's very reasonable to try. And prostate cancer being very common, we're doing this a fair amount, trying to keep the cancer under control. Now, we can't promise an overall survival benefit for oligometastatic disease for going after the metastases. So far, the clinical trials have shown a PSA control benefit. Now, whether that means down the line there will be an overall survival benefit, that's very hard to say. But it's relatively safe, relatively non-toxic if you're careful about the normal tissue. So that's oligometastatic. What about treating the prostate cancer in metastatic disease? Well, you've touched upon a very hot topic, basically because of a randomized clinical trial called Stampede, which has multiple kind of cohorts and multiple clinical trials. It's like think of what basket trial, right? It's like a trial with multiple pieces of it. This was the Stampede H trial, which took patients with metastatic disease and randomized them to prostate-directed radiation, moderate dose, not crazy dose, moderate dose, 55 gray and 20 fractions to the prostate versus no prostate radiation. And they found that there's no difference. But in a pre-specified subset analysis, if you have low metastatic burden, you did have a benefit. You did have an overall survival benefit. And so those patients with low metastatic burden, right? Not everybody, right? The trial didn't show everybody, but it said, okay, this group here, we're going to check out down the line. Low metastatic burden, those folks did have a benefit if you radiate their prostate. Now, why, right? Why? They already have metastatic disease. Why does it matter if you radiate the prostate to like moderate doses? Theoretically, just because you have metastatic disease doesn't mean your prostate stops creating metastatic disease. So if you can go after the source, maybe you prevent future metastatic disease down the line, especially if you have an effective systemic therapy like hormone therapy for prostate cancer. Works pretty well. So that paradigm, I think, is going to be seen more and more, where you treat the primary tumor in metastatic disease. We'll see whether it's just, I think it would be a good idea for like lung cancer with widely metastatic lung cancer with, like if they have a great, like an EGFR mutation, those new medications work really well. I would advocate for treating the primary lung tumor. Again, I don't prostate I'm a genitourinary guy. But I could see that happening in other cancer sites. There is an ongoing surgery study, right? SWOG 180, I want to say 2, but it's one of the SWOG studies, Southwest Oncology Group, right? Which also incorporates surgery, so you can be randomized to a local therapy versus not for metastatic disease, and that pre-specified local therapy can be surgery or radiation. So that's a very important study. If there are any urologists listening, please, open that study at your institution, start enrolling patients, especially radiation patients. I think the surgery arm of that study is going very well, but we need more radiation patients. So again, metastatic disease, newly diagnosed metastatic disease, think about opening that clinical trial at your institution.
So in summary, radiation therapy remains a viable option for men with prostate cancer, and new advances continue to emerge in this area. Dr. Yu, any final thoughts for our listeners regarding radiation therapy for prostate cancer?
The big take-home message I would say is radiation that was delivered 10, 20 years ago is not the same as the radiation that's being delivered today. It's very, very different. Our ability to spare normal tissue has gotten much, much better. If you are someone who's been diagnosed with prostate cancer, I would encourage you to at least have a consultation with a radiation oncologist. We've done multiple patterns of care studies showing that not everybody actually sees a radiation oncologist when they're diagnosed with prostate cancer. So I would encourage you to at least have a conversation with one and then make a decision for yourself as to which way you go. Join a support group if you feel that would help you. A lot of guys that I know that I treat love their support groups and are able to make connections that way and talk about prostate cancer and the kind of the emotional changes that can occur after prostate cancer treatment. And number 3, I would say, don't forget to vote. Especially if you're in a swing state. I don't care which side of the political spectrum you are, just be a part of our democracy.
Love it. So, Dr. Yu, it was certainly a pleasure to chat with you today on the Prostate Health Podcast. I really appreciate you taking time out of your busy schedule to visit with us, as you've really given valuable information to our listeners. Thank you again.
Thanks a lot, Garrett. It was a lot of fun, and hope to talk to you soon.
I want to thank you again for joining me here at the Prostate Health Podcast. Subscribe to the show on iTunes, Google Play, Spotify, or wherever you listen to podcasts. And please share it with a friend who may find this podcast helpful. We'll see you at the next episode.